This is Captain Marchese, and this lecture is going to be on the Diamond of Death, formerly known as the Lethal Triad, and how we can fix these issues in a Role 1 setting. About current clinical guidance to manage these trauma patients and how we can improve mortality in our own Role 1. The regulation that I use the most for this is the Joint Trauma System Clinical Practice Guideline, Damage Control Resuscitation. I would highly recommend looking at that clinical practice guideline if you are not familiar. We just have a diagram that's a short overview of the Diamond of Death. Basically, the idea is that each of these things are working against each other or for each other to make our patient worse or to make our patient better. And so by correcting what we can correct out of these four things, based on what's going on, we're going to improve the other three. Hypothermia. This happens to our trauma patients because of a decreased blood volume if they have massive hemorrhage going on. It's also could be due to the fact that we are cutting off all of their clothes, which is keeping them warm, or conduction. So conduction is, let's say someone is laying on the ground, their heat is being conducted to the ground. So they're losing heat that way. The physiology behind this, if their core temperature is less than 35 degrees Celsius, then we can clinically define them as hypothermic. When somebody is hypothermic, all of the enzymes in our body don't function the way that they're supposed to. And so some of those have to do with metabolism and they have to do with coagulation and being able to form a clot. So you can see how hypothermia is related to those other two already. And the treatment options that we have for this are, getting people off of the ground. And so getting them onto a litter as soon as possible. We want to start fluids as soon as possible, and we want to make sure that we're using like our buddy lights or our fluid warmers when we do that. And then we have our HPMK, so our warming blankets and wrapping them up. Acidosis. This basically occurs because a decreased amount of oxygenated blood is getting to our tissues for whatever reason, whether it's because there's not enough blood circulating and there's a massive hemorrhage. You can see how, that kind of all coincides with all of these. But oxygenated blood is not getting to the tissues the way it should. And so our body has to use anaerobic metabolism to function. And that's basically using glucose, and you form ATP, which is adenosine triphosphate, and that's what our body uses. And in the process of that, you get a byproduct of lactic acid. And so that lactic acid builds up and it makes our body more acidic than it should be. And so the enzymes that are always functioning in our body function at an optimal pH. And so when that pH is thrown off, then the enzymes aren't functioning the way that they should be. One way that affects us is that your hemoglobin, so your blood, binds or releases oxygen based on those differences in pH. So the pH of your lungs is different than the pH of your tissues, and that's how the hemoglobin binds O2 in your lungs and then releases it in your tissues. So when the pH is off, that gets thrown out of whack. We also have increased carbon dioxide, and that's converted into bicarb, and that actually is our body's attempt of neutralizing that. So you end up getting a buildup of bicarb during trauma or like shock as well. We'll get into that a little bit more on the next slide with some diagrams. So our treatment options for this is to mainly treat the underlying cause. There's been some studies of giving bicarb in shock patients, but it's not well studied and it's not necessarily recommended at this time. The idea is that we're going to neutralize acid, but it's really a temporary fix. And so most of the studies so far have shown that if you focus your time and energy more on fixing the underlying cause, that will in turn improve this more than the bicarb will. So we can do this by initiating blood products and fluids. That's kind of going to be our treatment option for all of these things because they all work together. And then not in a LISCO environment or a MASCAL, but if you have someone who is in shock, doing CPR is going to improve the acidosis because that's our way of making the heart pump and getting oxygen into the bloodstream. And so CPR is going to increase your oxygenated blood flowing through the tissues, and it's going to improve acidosis. But in our setting in a Role 1, if we're in the middle of a mass cal, we're not going to be doing CPR on any of our patients. Let's go a little bit more in depth of what is happening when our body is experiencing acidosis, and I don't expect you all to memorize this. It's just kind of for your understanding. When we can't use aerobic metabolism like we typically do, we go into anaerobic metabolism. And so you'll see on the left here, that's what's happening is we're trying to use glucose and we are forming ATP, which is adenosine triphosphate, and that's what our body's actually going to use for the anaerobic metabolism. Basically, because we're doing that, we're also creating lactate, and you can see there's a lot of other players in this, like pyruvate, and then there's NAD, which is nicotinamide adenine dinucleotide, and then there's nicotinamide adenine dinucleotide plus oxygen or plus hydrogen. And so, very complicated. I don't expect you all to like really get into the nitty gritty of that, but just being able to see that when we're doing anaerobic metabolism, we're creating ATP and that's how we're able to do it, but we're also creating lactate. And that lactate is building up in our tissues and it's making our body more acidic. Over to the right of that, I have kind of the formula that shows you when the carbon dioxide is building up, our body is going to convert that into hydrogen ions and bicarb, and we're doing that to try and neutralize the lactate. So, like I said in the last slide, there's been some studies that they're recommending giving bicarb, but they're also seeing that it's really just a temporary fix and you're better off fixing the underlying cause. Coagulopathy, basically the decreased enzyme function that we've talked about with the acidity, that will cause an inability for your body to clot, and we'll get into the nitty-gritty a little bit on the next page. Hypocalcemia and hypothermia, these are also causing your inability to clot. Hypothermia mainly because it inhibits platelet function, and platelets are important for forming a clot. Treatment options here, similar to other treatment options for the other parts of the diamond, but we're going to stop major blood loss. One option that we do have here is TXA. I would advise you to pause this for a moment and say out loud the dose of TXA. And then we're also going to give blood products or fluids. And another option that we have here is giving calcium, which we're going to get into a little bit more on these next couple slides. A little bit more about the coagulation cascade, which is basically just a bunch of steps that have to happen for us to be able to form a blood clot. And so on a day-to-day basis, when you're not in a major trauma, your body is using the intrinsic pathway, which is slower. This is for like minor damage to your blood vessels that happen just in day-to-day life. When we're having a major trauma, your body will shift over into the extrinsic pathway. And so that's this pathway over on the right. The main takeaway from this is very detailed and there's a lot of steps here. The main takeaway from this is that there's a lot of steps that need to happen for your body to be able to form a clot. And if you look closely at many of these steps, you'll see a small little green Ca2+. And so basically those are calcium ions. That's going to be super, super important because calcium is a cofactor in so many different parts of the coagulation cascade. And so it's very important for us to have calcium to be able to form a clot. And so in a major trauma, this pathway is breaking down at a lot of different places because of the acidity, because of the hypothermia, because of hypocalcemia. Hypocalcemia. This is the newest addition to our Diamond of Death, which used to be the Lethal Triad, because they realized how important calcium is for all of these parts of this what used to be the triad. And so basically decreased calcium happens for a couple different reasons. Main one in our setting is going to be blood loss. So there's usually a normal amount of calcium in your blood in your bloodstream, and so if you're losing a lot of blood, you're also going to be losing calcium. In other settings of like septic shock and situations like that, Sometimes it's believed that there's a shift from the calcium outside of the cells in the extracellular space into the intracellular space, so it shifts inside of the cells, and that also causes hypocalcemia in your bloodstream. We also have citrate, which is used as an anticoagulant when you store blood, and so that can cause hypocalcemia because the citrate basically binds to the ionized calcium and you're not able to use it the way you should be. So in a way, like our blood transfusions can be causing hypocalcemia. So as we talked about on that last slide, calcium is a very important cofactor in the coagulation cascade. So if we don't have enough calcium, we're not able to complete that cascade and form clots. And so that can lead to continued hemorrhage, which is only going to worsen all parts of this diamond of death. And so calcium is also important for your heart to contract properly. And so if you don't have enough calcium, you may have arrhythmias, or even, worst case scenario, you could have cardiac arrest. And so our treatment options for this, similar to our treatment option for every part of the diamond of death, is stopping blood loss, or, giving calcium based on the recommendations from JTS. So the current JTS guidelines are recommending calcium 1 gram IV or IO during or immediately after the first unit of blood products, and then again after every 4 units. That is the current guidelines. That has changed a lot over just the past, say, 5 years, because they keep doing studies on this and trying to figure out what the best dose range is for calcium. So, right now it is February 2026. A couple months from now, that could be a completely different guideline. And so if we were to get orders to go somewhere, that's one of the first things that I'm going to look up to make sure that I know is what's the current guideline for giving calcium, because it is ever changing. I'm going to wrap up this presentation with showing you this diagram once again, just reminding you that all of these things work together to make our casualties significantly better or significantly worse. And we can either improve our mortality if we attack one or more of these at the same time and fix them, or if we miss these things, it can significantly increase the mortality. And so we want to do what we can in our role 1 setting to improve mortality in any way. And these 4 things are what we need to think about when we're handling a trauma patient. One of these days, I'm going to write a paper where we, instead of that skull in the middle, put hypovolemia, because really that is at the center of all of these too. So we don't have enough blood or we're losing blood. That's going to cause coagulopathy. It's going to cause our patient to be cold. It's going to cause hypothermia. It's causing acidosis, and it's causing hypocalcemia. And so really, that's why we focus on massive hemorrhage as the very first thing in our March algorithm. Is if you see red stuff, you need to stop it, because it's going to make all 4 of these things worse. So overall, the goal is to improve our mortality and make sure that we're doing everything that we can at our role 1 setting to make sure that this casualty makes it to the next role of care. If you have any questions, feel free to reach out to me, and thank you for listening.